everybody that cashes a paycheck puts money into Medicare. Does everybody follow me? So my situation took me from working at St. John's Hospital. I emptied the garbage, I cut the grass, I mopped floors. I was talking about that today with the patient. My best job I ever had was the psych unit at St. John's. I passed out trays in the morning and picked them up, and passed out trays at lunch and picked them up, and every half hour I gave the patients a cigarette. Imagine that, 1976. That was part of a psychiatric wellness program. We were passing out cigarettes, okay?
People didn't smoke.
No, they probably did smoke, but if the psychiatric unit, if one person did it, everybody did it, okay? Pay attention to what I'm talking about now. I'm giving you personal experiences so that I can teach you about Medicare. Medicare comes in 4 flavors today. Part A, Part B, Part C, and Part D. And I'm going to run you through the history that I lived through and watched. And let me tell you things along the way, such as, if anybody here had a total knee replacement or hip replaced 30 years ago, you know that you stayed physically in the hospital. For how long?
2 weeks.
How long?
2 weeks.
2 weeks. Is everybody with me? And guess what? You didn't pay any money. It was covered by Medicare. So how does it happen that we go from a system that you could spend 2 weeks in the hospital when you got a joint replaced? And guess what? That's elective. Does everybody understand the difference between acute hospital care, emergency care, and elective care? Elective means you have an ailment, you go see the doctor, and you and the doctor elect to fix it on a certain day. So you go in, you got arthritis in the hip, and you elect to fix the hip. That's much different than Aunt Mary falling down the step, breaking a hip, and having to go into the emergency room and getting it fixed. Guess how long they stayed? Does everybody follow me? I'm running through the history so you understand how we've been scammed. Okay? So again, A and B. St. John's Hospital, I worked there from 1974 until it closed. My father he was a physical therapist. He ran the convalescent center, which was in the north. Right now it's owned by St. Barnabas. But it had a 100-acre facility with a nursing home, okay? It also had a drug and alcohol rehab. It also had an acute care hospital. Does everybody follow me? It also had an urgent care center. Does everybody know where Wexford House is? That was St. John's. They built that. That was their urgent care. And just by the way, the reason it failed, the McCandless ambulance took everybody to Passivant instead of to the urgent care. Does everybody follow me? So again, I watched this, guys. I lived through this. That's why I'm making you understand it so you appreciate where we are. So what else did they have that I thought was pretty unique?
Can you turn it up a bit?
And you guys may know her, Mrs. Graham. She ran the Hubbard Street Clinic. If you guys know the north side, as you go up Brighton Avenue and you make your way to McClure Avenue, St. John's was on the corner. 1 block up on Hubbard Avenue, Mrs. Graham ran the clinic. How did you get an appointment? You made a phone call. And guess what? I had 2 uncles that were physicians on staff there, Dr. Nicolette and Dr. Santora. And both of them, for being on staff, had to give 2 days a month at the Hubbard Street Clinic, and they had to do free operations to anybody that needed one at the Hubbard Street Clinic. Does everybody follow me? Because what we're going to go through, you're going to hear, why did we go to Part C and D of Medicare? To insure more people and to make sure everybody had health care. Well, guess what? I was there. In 1974, if you lived in the north side and you didn't have a nickel, you had the same doctors that were operating on people who had a nickel see you free in the clinic and operate free if you needed this. Everybody follow me. And this was happening all through the Ohio Valley. AGH was the tertiary care center in case you had to have your head operated on or your heart operated on. But all these community hospitals worked, and if you were on staff, you provided free care. Does everybody understand that? Because I'm going to run through this, guys. You're not going to believe what happened and how it all changed. So that's why I'm giving you this, so you understand how to pick the right Medicare plan. That's today's theme. I'm giving you the facts that I saw happen as a primary care provider in this community. So what did we have, and when did we have it, and how did it change? I'll try to keep my personal opinion out because I want it to be a learning experience. But as you see, I'm pretty passionate about this because I saw St. John's in 1979. They had everything. Literally, think about it. Drug and alcohol rehab, a clinic that they're taking care of the community free. The doctors are providing the service free. They have a Valencia Woods, it was called, was the name of their 100-bed nursing home that sat on 100 acres of ground. Perfect place to get recuperated. My father was a therapist. I saw many strokes go out there. The people got better, went back to work. All those services were there functioning. And guess what? It closed. I've closed 5 hospitals. St. John's was the first. Anybody familiar with St. Francis that used to be up in Cranberry and in Lawrenceville? That's where I trained. I closed that one. Suburban General, closed that one. West Penn Hospital, closed that one. Divine Providence Hospital, closed that one. And guess what? I was on staff at all of them, and every single one of them provided excellent care. Does everybody follow me? This actually happened. So back to the timetable. 1965 was Medicare Part A and Part B. A is hospital. B, doctor, and we'll put services. Here's my opinion from my experience. When my uncle started practice in Pittsburgh, Pennsylvania in 1929, he was the doctor. He had a horse and buggy and made his rounds. And he trained and operated at St. John's Hospital. And he ran everything. Does everybody follow me? No one told him what to do or how to do it. He was trained as a physician, and as a physician, he practiced medicine. And he did what he did, and guess what? There were no pharmacists. There were no physical therapists. This is 1929. Does everybody follow me? All these services we're going to talk about, I can tell you when they didn't exist. The doctor did everything. And now as a practicing physician in 2022, I don't make the decisions anymore, guys. As you, my patients, know. What do I have? And it's hard because I'm used to saying, oh, okay, we'll get the sonogram tomorrow. I'll call you back, and if we need to, we'll see the doctor on Friday. Now my staff yells at me, Dr. Cochran, we got to get it approved. Why tomorrow? Because they got to get it approved. So I went back, and again, that's why I'm sharing your personal experiences. 1991 at my McKnight office on McKnight Road by the Ross Park Mall at 9 o'clock at night, I locked my door. I see patients Tuesdays and Thursday nights. Lock my door, taking my coat off, there's a knock on the door. Dorothy was about 4'2", and her husband was about 6'8". And she carries him in, and we sit him down, and he's wheezing. Never met him before. Listened to him, something was in his lung. So I called Terry Obringer, a pulmonologist, and I sent him down to Allegheny Terrace. We were at St. Francis at the time. Sent him to St. Francis Hospital. Terry did a bronch and found cancer. Dr. George Pavlik, who was the oncologist there, we called them up, said we found the cancer. Before 9 o'clock in the morning, so less than 12 hours from the time he walked in my office, he was getting chemotherapy. That was 1991, guys. We've gone backwards. Why? Because they're not letting the doctors run things. And it's the doctor's fault. These companies can't practice medicine unless they own the doctors. But once they own the doctors, they call the shots. Everybody follow me. So I'm giving you the history, and I'm telling you what we did in 1991. In less than 12 hours, we diagnosed and treated lung cancer in Pittsburgh, Pennsylvania, the St. Francis Hospital, which is one of the 5 that I closed. And now I'm telling you, when someone comes in my office and I know they're sick, my staff yells at me because I say, well, we'll get you a chest x-ray and I'll call the doctor, he'll see you tomorrow, and we'll do it. You can't do that, it's gotta get approved. Is everybody with me? I'm running through it and beating it up, guys, because you have to understand this. All right, so what do we find? 65, Part A and Part B, and that's what they cover. And how did you take care of patients that had no insurance? 2 things about this time period. Number 1, they always use the word proud. I'm not sure if I would say that same term, but the only people that didn't see Mrs. Graham didn't see doctors. Otherwise, you called Mrs. Graham because you knew the Hubbard Street Clinic would take care of you. So the people that didn't have insurance at this time chose not to have insurance, or they were unfamiliar with the services in their community. And that's social service, which once again in 1929 my uncle didn't have. Social service was an outreach identified by the physicians, which, by the way, let me tell you, when I started practice in 1991 at little suburban general hospital, I was mandated to attend 5 meetings a month. Internal medicine, because that's my specialty, general medical meeting that you had to be on a pharmaceutical committee meeting, you had to be on what was called M&M rounds, mortality or morbidity rounds, so you reviewed what was happening. And then I chose lecturing. You know, as a physician, you could lecture, you could try to raise money, you could provide different services in the community, but that was all part of me being on staff at the hospital. And guess who decided it? The doctors. You follow me? We're not bad guys if we're allowed to make decisions. And back in the 90s when I started, we were allowed to make decisions. So once again, where we are with things are, we're now, people that don't have insurance are choosing not to. I'm telling you, I was there, let's say 79, was when the change occurred. And what I saw was St. John's, Divine Providence, West Penn, Suburban General, and St. Francis. Was there favoritism in healthcare? Yes. And I learned it early. St. Francis Hospital, 1994. I was put on the executive committee. You have to be voted on to the executive committee. And what happened was, I met a guy by the name of Dr. Potter through my accountant. He was a family practitioner, very, very busy. I used to see patients Monday through Friday, 9 to 5. I met Dr. Potter and he said, no, that's not how you practice. And I said, well, that's how I was taught at St. Francis to practice. No, you gotta go to nursing homes. So in 1994, I started going to nursing homes. No internist in Pittsburgh was going to nursing homes at my age. They were all doctors that were retiring, took care of the nursing homes. And he told me, go to the nursing homes Monday, Wednesday, and Friday, and see patients Tuesday night, Thursday night, and Saturday night. And I listened to him. And before you knew it, I had the largest practice in the North Hills of Pittsburgh. And so they put me on committees because of the volume of patients that I had. So I'm at a committee meeting. How things come up in healthcare, believe it or not, Draw straws. You guys know how to do that? Ever done it? A pilot program. Has anybody heard that concept? A pilot program in medicine is a program designed for the purpose of, and I used to always think, benefit the patient. So, 1983, I trained in Baltimore, an affiliate of Hopkins. They used to call it the Country Club on the Hill. And it was an amazing place. It was in Towson, Maryland. And it was just phenomenal to see what Hopkins was like. It's the hub of the world. Anybody that's sick goes to Hopkins. And when you experience that, you kind of get a standard in your mind. And so what happened to me in 1983, as a student in Baltimore, I get a phone call. Dr. Oppola, there's a patient in the emergency room with pneumonia. This was Friday, I'll say June 30th. Because I'd have been on the 2nd, 1st. 30 days has September, April, June yet. So now it's Sunday, the 2nd. July. Just an aside, but it's true. Don't ever get sick in July and go to the hospital. You know why? That's when the new residents start. Okay? That's that learning curve. So back to pilot programs. Again, guys, I'm giving you what I went through personally to give you my spin so you understand Part A, B, C, D of Medicare and how to pick what you need. Okay? So the pilot program that I was involved with, when you're in the emergency room and you're woke up at 4 in the morning, you go see the patient, you talk to the patient, you talk to the family, you examine the patient, you get the blood work, you get the x-ray, you make the diagnosis of pneumonia, and you write orders. Let me see if I can still remember. ADCA, Van, DeMills. That's how I got through medicine. Patients admitted, what's the diagnosis, what's the condition, vital signs, how often do you want them, what are the allergies, everybody follow me? That's how you did. So you would get up in the middle of the night, you would get down, examine the patient, look at the x-ray, call the attending, and say, hey, it's Matt, I'm seeing Mrs. Jones, I see a right lower lobe infiltrate, I'm going to start her. Back in those days, we used, what do we use, flagyl, we used a lot of flagyl. So you write the orders, and you go to bed. That's what I did. Friday the 30th, 83. Actually, I think it was 82 now that I think about it. So Sunday I'm on, and you notice we were on every other day. That's how you learn. I have 2 sons in medicine right now. I have a son doing his 2nd year residency in Richmond, Virginia at VCU, and they stay till midnight. And that's being on call. This is being on call. So 2 days later, I'm in, they call me, Dr. Oppola, we have a patient down here with pneumonia, we need to see you in a minute. Okay, come down, do the same thing. I go back to bed, and I get a call. There's junior and senior residents. Senior is the top guy, chief resident. Junior is the person like yourself, and they're a year ahead of you, so they get to tell you what to do. And so the junior resident calls me, he says, hey, Oppola, you gotta go down and do a gram stain. Anybody know what a gram stain is? Okay? You take a microscope. I like my microscope stand. Okay? And you put the slide here. So you have them cough up what's in their lung. You put it on a slide, and then you stain it. And the stains that you use, your hands turn out to be red or purple for about a week. So no one likes to do gram stains, and if you do them, you want all the equipment. So I'm looking around for the heavy-duty gloves. I can't find them. I'm asking them where the slides are. No one can find the slides. So I'm like upset that I could have been sleeping already, and here I am doing a gram stain. So what do? I go back to bed, and I get called by the chief resident. And I can't tell you what he said, but let's just say, capita, bleepity bleepity bleep, and if you don't get down there, bleepity bleepity bleep, you're fired. So of course I go right back down, find all the stuff, and do a gram stain. That was part of the pilot program for DRGs. Everybody know what DRGs is? Diagnostic Related Guidelines. Now again, guys, I didn't know this in 1982, 1983. I lived it. It was only now that I'm older that I look back, I see the scam. At the time, I was going to get thrown out of the program if I didn't go down and do the gram stain. In my mind's eye, I couldn't think. Like, we put them on what's called broad spectrum antibiotics. And that sputum sample would have been done by the nurses the next day, sent down to the lab where they do gram stains every day. And so we would have had the information 7 hours, maybe. All of a sudden, they're making us do the gram stains in the emergency room, and they're making us go from broad spectrum antibiotic based on the gram stain to narrow the antibiotic choice. Everybody follow that concept? So I was part of a pilot program in 1983, and the objective was to develop diagnostic related guidelines to mandate for Medicare participants. And guess what happened? We notice now that we're hanging the antibiotic in the emergency. Remember I told you 2 weeks for a hip and a knee, 4 weeks if there was complications? This was the beginning of length of stay. Does everybody understand length of stay? That's depending on your diagnostic related disease, there's guidelines that determine how many days you can stay in the hospital. And I won't mention the name of the hospital, but I can tell you that I rounded in this place in the 90s, and I rounded in this place as recent as 2017. And in the 90s, when you rounded, the nurse would talk to you about the patients you had in, what was going on, and you will put together a plan based upon were they moving their bowels, did they have any signs of infection, if they had surgery, was there any drainage, all the different things that go into are they getting well. 2017, length of stay. You had stand-up rounds to see when the patient was leaving. Does everybody follow me? That's a change. Just like 2 weeks, 4 weeks for hips, and now it's 24 to 48 hours. Same situation. You had face-to-face dialogue with the nurse about your patient. Now you have stand-up to see when the patient can leave. Does everybody understand that concept? I'm developing these so you understand them, okay? So, when I realized what I did in 1983, it was probably 1990 to 1994. And 94 was the big one. When you're a resident, you're getting paid. When you're getting paid to provide the services you provide, that's when you saw how you were controlled. Okay, does everybody follow me? I had a contract with the hospital as a resident. I had to do what they told me to do. I got one funny story I can tell you. So I'm at St. Francis Hospital. I happen to be related to one of the head nuns. And long story short, I'm on call on Super Bowl Sunday. No, it wasn't Super Bowl, playoff Sunday, and the Steelers are playing. So I go back to the call room, and there's no TV. And I mean, I was almost in tears. I'm a Steeler fan. So I'm walking out, and I walk past the waiting room for the ICU, and there's a TV sitting there on wheels. Around, took it back to the call room, didn't say anything to anybody. That was Sunday. Tuesday was Grand Round. 500 people, a lecture by Dr. Holsinger, who's the governor of the American College of Physicians. And after the lecture was over, Sister Rosita comes running out, taps on the microphone, "Don't anybody move." And she said, "We had an incident. Somebody took the television out of," and she went on to explain, and I did put it back after the game, right? So long story short, she starts to tell the residents they're gonna lose their lunch privileges. You know, we didn't pay for anything back then. And so I finally, because she said, "Please stand up," whoever did it. And of course, I'm not standing up. No one knows I did it, no one saw me. But once she started taking away everybody's privileges, and everybody starts going, "Come on, admit it." So I stood up, she called me into the front of the room, and I had to do community service with her for 3 weeks. But my whole point to it, from my vantage point, is we lived in the hospitals, we were owned by the hospitals, you had to do what they told you to do. Why am I bringing that up? Because of healthcare today. So I was owned by the hospital under contract to provide medical services. Resident, hospital, I'll put influence. Does everybody understand the concept? And I saw this like 1990. And it made me think because of what I saw with St. John's in 1979. And then I went to visit my friend, Dr. Melchijah Spragans, who was chief of neonatology at Johns Hopkins. I don't have time to tell you all the stories, but one fun one. They made me knock on his door at noon because they had a test change on a Saturday. No answer. No answer. I'm walking away, and it was one of those doors that can come off. And as I turned, he was in pajamas. He took a nap every day from 12 to 1 o'clock. And of course, the residents that sent me there at 12 knew that. And he saw that they did that to me, and he kind of special place in his heart. Long story short, he made me lecture at Hopkins. Because he said if I could lecture there, I could lecture anywhere. And of course, I haven't shut up since. But my whole point to it was, what I saw from 79 to 90 in the healthcare system, doctors were in control. Look at the dates. 1994, legislation allowed Part C of Medicare. Does anybody know the difference right now? You don't need to because I'm a teacher. Does anybody know the difference between A, B, and C right now? A, remember what I told you? Off hospital. B, services, durable medical equipment, that services, say you need a walker. And doctors, the office visits, okay? What happened was, Part C came, they got A money, plus B money, plus a 10% profit. And please look this up. Kaiser Permanente was one of the first ones. And it was set up by Nixon way, way, way back. Not as a Part C HMO, but it was set up in order to produce. So they set up a managed care healthcare system to get better production out of the workers. So everybody follow me? Look it up, guys. You can track it. That's why I put 79 to 90. So what did I witness? What I witnessed was in 1994, remember what I told you? I would come onto the floors. I had a large practice, so the head nurse would sit with me, and we would literally go through every chart. I'd have a stack. I'd have 20 people in the hospital. And you would take that off, and you'd open it up, and you'd say, "Oh, Mr. Smith had a gallbladder. What did the surgeon say? Oh, Dr. Hennig took the tubes out. He's going to feed her today. If she's good, she'll go home tomorrow. She move her bowels. Yes. Did she have a fever? No. Is she in therapy? Yes. Boom. Next." And you did that with every case. And so you'd walk on the floor. The nurses would get up. They would get the charts and prepare to go on rounds with you. So I walk on the floor, 1994, 4th floor at Suburban General Hospital, and I'm at the rack putting my charts, and I look at my list and I go, "Oh, where's so-and-so and such and such?" The case manager has your chart. I never heard the word before. So in 1994, the case manager was allowed to touch my chart. And let me tell you what that means, guys. 1992, I'm still on a pass, and I don't round there every day, but back in 92 I did. And I saw, I'll never forget it, Mr. Murphy comes into my office with appendicitis. And I just started the office. We were at the McKnight office from 6 o'clock to 9 o'clock. And so I said to him, I'll call the emergency room, I'll send you up, they'll get you tucked away, we'll see what surgeon's on rotation, and I'll be up to see you after office. No one called me, I didn't talk to anybody. 9 o'clock, I go up to see him, I pulled the chart off the rack, I didn't look, I just looked for his name. Pulled the chart off the rack, went in and saw him, wrote a note. I was disciplined for 2 weeks, I couldn't admit patients because I touched another physician's chart. What happened when he went to the emergency room, they said that he couldn't say who his doctor was. And if you know me and you know my patients, everybody knows who I am, how I am, and they know to tell the person when they walk in who their doctor is. So my touching the surgeon's chart got me 2 weeks of not allowed to admit patients. Okay? So what happened when the doctors controlled things, you had rules. I was upset over the situation because it was my patient that I sent up there, but I'll never forget it. Ralph DiStefano was the administrator, and he called me, said he wanted to have lunch. And at lunch he said to me, grow up. And I looked at him and I was like, what? He said, did you call and talk to the surgeon? Did you call the surgeon and tell the surgeon the patient was coming up? Did you give anybody information medically about the case? And as I started to say, no, but, he went like this. And he says, you have to understand how the real world works. There's rules and you have to follow them. And so again, guys, this is in the 90s that I see this happen as I practice, and all of a sudden in 94, there's not a chart that belongs to me on the floor, and a person they're calling a case manager who has to be an RN with clinical experience. That was the requirement. So an RN with clinical experience takes my chart and puts together what's called, remember the DRG I told you about? They make a DRG and determine how many days I can keep the patient in the hospital. Sorry about that, guys. That's probably my book he needs paying. So again, I physically, personally had this happen to me, 1994. So then what occurs, 1997. Now remember, Part C is in. And by the way, before Part C, there was legislation that came out, and that was also 1983, that changed all hospitals from non-profit to profit. And I remember giving this lecture in 1996. So you can imagine since then. Just the commercials. Just the commercials. Because once they went for-profit, they were allowed to put commercials on. From 83 to 96. Just the cost of commercials could have insured the world. Does everybody hear me? And you guys all know we're about to talk about all the stuff you get from October till December when it's time to sign up for Medicare. The amount of money spent since they went nonprofit is unbelievable. So what do I next see? 1997, I get invited, I can put it here. I get invited to a church on the north side of Pittsburgh behind Allegheny General Hospital, 9 o'clock at night, right before Thanksgiving. And presented by Insurance Services, the managed care concept, and how I needed to join or I would be out. 1997, I physically was there. 250 primary care doctors in the basement of a church right before Thanksgiving, 1997. And so I went, and I listened to what they had to say, and I thought, but they made you feel like if you didn't join, you were gonna be left out. So I spent $2,700 that night, and of course I lost it because it never materialized. What it is, and what I've learned, you know how you get those calls, call free for such and so, and we'll send you out, whatever? That's a marketing tool, so they see how many people heard the commercial and how many people respond. I didn't know it at the time, you know, just learning how to practice. And by the way this all happened, a quick aside, you'll hear commercials that say doctors don't get any lectures on nutrition. That's BS. We get a lot on nutrition. But how many lectures do you get on business? We're not businessmen. We weren't set off in the world to be businessmen. It's not supposed to be set up as a business. You're not supposed to be motivated by dollars and cents. And yet, as we're going to talk, you're going to see how it changes. So again, from 97, when I spent the $2,700, I started to see that there was a change coming. And then 2004, and by the way, 1994 was Clinton, so it's both parties. Because in 2004, Bush put Part D. And we're going to talk about it, and I get through it quick, guys, so don't worry about how late it's running. You have to understand how this works. Again, I was scammed, so I'm not saying that I was above it all, but now that I lived it and I look back, you see how it works. They change something and have you chase after something while they do something else. So they let us know that if we get electronic medical records, that we can get more dollars and provide better services. So you spend the money to get computerized, and it's ridiculous what you have to go through. So while you're doing all that, trying to load the DRGs in, because that's not how you get paid, along comes Part D. And now we're back to pharmacists. Does everybody see the clutter? 1929, I had an uncle that called all the shots. He was a surgeon. He did what he wanted, when he wanted to. He provided free care at the clinic 2 days, and he provided free surgeries anybody that went to that clinic. That was part of him being on staff. And now we have it where in 2004, the pharmacist got in with the case management. Remember, the case management had the DRGs. Now the pharmacist, and again, it's all unfortunately dollars and cents, guys, but what the pharmacists now were able to do was get the patients coming to them because of the managed care products that started to evolve. Does everybody understand the concept? And that's why I'm setting it all up, so everybody picks the right one at the end of this. Part C had all the commercials. And what do they promise you? It's the same thing every time. Eyeglasses, free dental care, hearing aids. And before Part D, prescription plan. But what was it really? It was them controlling what you got. And I was blown away that my patients went generic. Pre-Part D, my patients wouldn't take a generic drug. They would not touch it. They felt that they only wanted the ones that were made by whatever company it had to be. Generic or second rate. But what happened? Managed care with the commercials, Part C, took off. Everybody was signing up. Why? Commercials. Promises. Do we get anything for free? We taught that from a youngster. And yet somehow, when they say free eyeglasses, free hearing aids, free dental, I mean, it just attracts people. And I was shocked in my own practice. My patients didn't go to that, but guess what happened? Just like I told you, they call you up to see if you call back to get the free trip to wherever. That's a marketing tool. So what did the marketing tool say? Remember, my patients would not take generic. So managed care came out like gangbusters and it flattened out. So what did they do? They went to the employers. Does everybody follow me? We had, when I say we, I was working with Dr. Pond. Was it Clark Candy? He did a lot of, he taught me a lot. He's a guy who had me go to nursing homes, and then we also went to companies, like company doctors. And it was remarkable how we had Schaffner Manufacturing. I mean, we had many. We probably had 15, 20 companies we were taking care of. And all of a sudden, managed care made the deal with the companies. And my whole practice changed. Because now it wasn't up to the patient. Does everybody follow me? Prior to that change, the patient still decided as you're going to October till December and then January to March, the time frames that you have to make your changes. When the change is made in Part C, you have to stay in until it's time to come along. As you'll hear, one of the benefits of the old-fashioned original Medicare, you can change anytime to anything you want. And we'll go over that. It only takes 5 minutes. Okay, but I'm running through this again to bring you guys up to speed. So when the marketing brought the commercial companies in, I saw everything change. Now, healthcare systems. And they contract with providers, pharmacies, and durable medical equipment, oxygen. Everybody follow me? And this hit, let's say, hit and stuck. We'll say like 2008 to 2010. And by hit and stuck, I don't know if you guys know the name Dr. Nicotero. He invented the hemodialysis machine. He had an office on McKnight Road right beside Vincentian Nursing Home. And I bought the practice. He and my father were good friends. I bought the practice in 1996. It had x-ray, it had lab services, pulmonary function test, you name it, it had it. So a patient that would be new would come to me, and I would interview them, and then they would go get chest x-ray, lab work, blood work, everything done, and then I would see them and review. One-stop shop. When the commercial companies got into managed care, they convinced my patients that they had to go wherever the network was. So I had patients there with Dr. Nicotero for 40 years. They got their labs, their x-rays, all those services there. Now they couldn't if they were in managed care. You had to go. So I was shocked. How could my patients accept generic medications? And how could they be so inconvenienced for their health care? Does everybody follow me? That's what I witnessed. So now we're in 2010, and I see the change in healthcare. And all of a sudden, ICD changed from ICD 9 to ICD 10. Does anybody know what that is? International cause of death. Started in the 1800s, where countries spoke to each other to try to figure out better ways of wellness and healthcare. A good reason to start the ICD, okay? So ICD 9, this revision occurred that by 1994, mostly all of Europe was under the ICD 9 code revision, which ultimately became ICD 10. And I'll tell you what that means. America didn't do it, because what that was essentially government-run healthcare. What does the ICD code do? The ICD code to a computer gives you the matrix. Who's a baseball fan here that understands it? What happens with the baseball matrix is they decide when the muscle gets tired. So we all grew up watching pitchers pitch 9 innings. Well, the matrix says that you gotta get them out after 5, because that could be too tough on their arm. 100 pitches or 5 innings. And again, it's computer design. How does it do it? You have to have data to go in. Well, ICD 9 code for a foot, '48 codes. What does that mean? This is where the ankle sits. So you describe the toes, you describe the ankle, you describe the skin, you describe it in such a way that you code it so that another country understands it. Now all of a sudden the ICD-10 code comes, and there's 180 codes. Does everybody follow me? What does that do? That enables the computer person to know in fine detail what's going on with that ankle. Does the doctor need that much information? No, ICD-9 worked well. And we had the leading healthcare system in the world at the time it was all developed. And we developed everything from there forward. But it changed. And again, remember I said both sides? It changed with what we now pleasantly call Obamacare. What else changed with Obamacare? And again, guys, the reason I have to belabor this and give you it all is so you understand it. With Obamacare, we changed the delivery. Personal experience, I took care of my grandfather and I took care of my father. And they both had original Medicare. My father, pre-2010, paid $650 for both he and my mother. And then they had a supplement Medigap that was an additional, I think he said $250. So that was what the two of them paid with the original Medicare, no deductibles, no co-pays, all that kind of stuff. When Obamacare hit, he went up to, I think he said it was $2,800 a month. Because the way it's designed is it's based on your income. And you have to buy it through these exchanges that they set up. And so what would happen is that it's the matrix. Remember what I'm talking about, it's all computerized. So you go in, you had choices of A to N in terms of, does everybody understand Medigap? You get your Medicare Part A, Part B, Part C, and Part D, wherever you fit into. And then what is Medigap? It covers the gap. So what does that mean? If you have original Medicare, it only pays 80%. So how do you pay that other 20%? Either out of your pocket or you get a Medigap coverage. And remember what I told you, my parents paid $250 extra for that, but they never paid for anything. And my mother had colon cancer with surgery, my father had multiple operations, open hearts, etc. Never paid zero for anything. But it was expensive. And that's what we're gonna get to in a minute, but my point is, the reason I walked you through all this was to show you how it all changed, and from 1982, when I saw the pilot program of the DRG system, diagnostic related guidelines, all the way to 2017, when I saw the most important thing for stand up in the morning, and I'm sad to say it still happens today, length of stay. I still get contacted from social service, hey, Dr. Hoffman, when you discharge the patient. You know they're on such and so and so and so, and if you don't get them out by such and so, then they're gonna get charged extra money. Does everybody follow the concept? So I brought you up to speed from what I'm doing. So now, back to the original question. How to pick the right Medicare plan. How do you pick it? Do you want original Medicare? %? You're responsible for 20%. Part A, the deductible in Pennsylvania is anywhere up to $200. Part B can be up to $1,500. And then the programs, it used to be A to N, remember? Now it only goes A to F. They no longer allow G, H, I, J. I think you can still do L and N. And my father had the one that was high deductible. But once again, the only reason I bring them up is I personally took care of them, so I do. And again, what they had before Obamacare, the cost that they had for the original Medicare covering the Medigap, they paid for nothing because I took care of everything. And again, they had the money to do it. So it comes back to how do you pick it? You have to have a budget. So the most important thing is a budget for healthcare. How do you design that? Talk to your accountant. Your accountant will know the industry. I used a guy, he was great. Al Fortunata, he was in Bellevue. He owned Insurance R Us. That's what he called the company. He was my patient. So I had him talk to my father. My father had his insurance out of Minnesota. You're no longer able to buy insurance out of Minnesota since Obamacare came because you can't be interstate. But back when he had it, that's all they paid. You know, the bottom line is you have to know what your financial budget is, and that's how you design it. Because A and B is with the original. A plus B plus C is with managed care. And managed care comes in PPOs, HMOs, fee for service. So you see the menu is large. What you want to do is assess your own health care because you have to know what kind of shape you're in. And you have to determine what your needs will be. What needs are we talking about? Hospital coverage, post-hospital coverage, and that comes in rehab, skilled nursing unit, or long-term care facility. What does that mean? If you had COVID and they had to intubate you and they had to put a hole in your neck called a tracheostomy, by the time you're ready to go back in the real world on your own, it could take anywhere from 6 months to 2 years. So that's how you end up in a long-term care. But you have to look at your health and factor that in today, especially since we're in this COVID world. Point being, these are the services you have to know because these are your costs. And then what you want to look at is the days. What does that mean? Original Medicare used to be 21 days of service after you were in the hospital that you could have at any facility that you chose. Now, it's based on the diagnosis, but if you're original Medicare, you generally get 14 days. I don't think you guys have to worry because you're a CCRC, but just for the discussion of how this works and what you need to do as you pick it out, again, guys, talk to your accountant because they know your finances. And as you talk to your accountant and you tell them you want to pick the best Medicare program for yourself, and you understand that there are experts out there to guide, do you have a referral? That's who you talk to. Because trust me when I tell you, they do. Because the accountants know this world. They know what's going on in this world. They know the dollars and cents of everything that's happening. So that's the way you approach it. I do not recommend Medicare.gov. I do not recommend calling up the insurance company and asking them. You want to get an expert referral from your money person. And that could be your attorney. I'm not saying it has to be an accountant. Whoever advises you, you may have an attorney that's your financial advisor, but it all comes down to dollars, guys. That's where we are today with choosing the healthcare. So again, let's say you have diabetes, you have had some type of cancer, you've had open heart surgery, you've had complications of your diabetes, and let's throw something else in there, that you drink too much alcohol, okay? This is going to factor in to what's called post-hospital care, okay? And please, guys, understand this. Why it happened this way, I don't know, but the matrix tells your insurance company all this. Like, they know you before you call them, because all this stuff's on the internet. Unless you're like me, I'm not computerized. But most physician practices, if they're owned, they have to be computerized. So all those codes and everything are done when you walk out the door. So the information is out there, and they talk about the cloud and the superhighway. All the information's out there, guys. I own a personal care home, and the way our people market it is you can get on a computer program and you can find out in Pittsburgh how many people need a personal care home today. That data is out. Does everybody follow me? The computerization of the world has happened, and all the information is out there. What you want to do is use it to your advantage. So through your accountant, you get the referral, and I would not recommend somebody that sells car insurance, if they're doing 3 or 4 different things, they're not the expert. You want to find the person. Like I said, I wish Al Fortunato was still alive, because he understood. He took my father, he got the program out of Minnesota, and all their life they didn't pay anything. Point being, there's experts out there. Get it through your accountant or your attorney or your advisor for your finances, because it's the most important thing to make the decision that's going to enable you. And again, I'm putting here as health, and then we'll put over here health. And this guy is 93 years old, no medications, exercises 4 times a week, goes to bed at 8 p.m., and he wakes up every morning at 5 and does his exercise, okay? Those are the 2 extremes I would tell you. And again, I give this lecture to a lot of people, so I tell the persons that their budget's the most important thing. If you're in a situation, and sadly, the indigent population is more along this line, and sadly, it's happening even in teenagers, where because of all the junk we're eating, it's called NASH, non-alcoholic steatotic hepatitis, where they get disease in their liver from what they're eating. Whole point is, this is the spectrum. Where do you fit in? And you talk to the expert that your money person refers you to. Yes?
Who are you referring to? Who is that accountant or attorney referring? You keep saying, ask them for a referral, but what kind of?
It's a Medicare insurance expert. And they know they're out there. And these are experts. And they can, I know it and understand it from what I do and what I did with my grandparents and my parents. but there are experts out there. And again, guys, I'm not ripping on anybody, so I shouldn't even say the name, because I don't want any liability, but the commercial's not where you find out. Like, they have all the stars. Who's the guy who's the quarterback? Joe Namath. I laugh when I watch that thing. You know, again, you don't get anything for free. You're not gonna get anything ever for free. And come on, who uses the eyeglasses, the dentures, the hearing aids? Because what they give you is not the standard that you would probably purchase yourself. So don't be sold by the gimmicks. Look at what your needs are. And if you're at this side, you're gonna have hospitalizations. Well, what happens? They get you out of the hospital now in 2 days. So what does that mean? Do they pay for post-hospital care? Skilled nursing care, rehab, long-term care? Once again, you guys are in the CCRC, so I think that's all covered for you. But what I'm telling you is, as you make these decisions, every plan has a plan. So they can tell you, if you go into the hospital and you have open heart surgery and your wound doesn't heal and it gets infected, how many days do you get to go to the skilled nursing facility? And what you'll find out, oh yeah, 0 copays, no deductibles. Well, guess what? You can't stay at that place. You're not going to be able to go there. They send you home. If you haven't seen the commercials, now the big push is care at home. Why? No one has the money, and it's all up to your insurance. So please pay attention to post-hospital is the big one. And then durable medical equipment. What does that mean? Wheelchair, all the way down to toilets, walkers, all those things. See what they pay for. Okay? And then services that you want to pay attention to when it comes to the needs you may have are the home care and hospice services. These are taken care of by Medicare. If you're into regular Medicare, I can tell you guys, you don't need referrals, you can go anywhere you want to go. You know, like, remember I told you my staff yells at me when I say, hey, Mr. Jones, you can go get your sonogram tomorrow, and we'll call the surgeon on Friday. Medicare, you can do, if you have the original Medicare, I can still say that to you. I can still say, we're going to order the CAT scan. You don't need a referral, you don't need anything but the doctor's prescription for that. That could be very important if you're in this category. If you're in this one, it may not be, but remember, those are the things that the expert will take you through. And again, expert, what does that mean? Where do they get their money? The insurance companies pay them. You follow me? Like, they're not making money off of you. Whether you buy that product or not doesn't mean anything to them. They're getting these dollars from providing you the information. And again, who is the person to ask? Your person that controls your money. Because they know them. Everybody knows, like financial planners. When I first got my first jobs, I don't remember even hearing the term, back in the 60s and 70s. But that became a big thing as people were living longer and retiring and staying alive longer, financial planners. Just like I told you, when my uncle started in 29, there were no pharmacists. It was the school of pharmacy in the building, but the doctors decided what and how much to use. It's changed now. So does everybody follow me from the changes I ran through to PJOP? So you understand Part A to Part D. Please make certain that you get accurate information about Medicare cost to you. And please do not purchase based on a commercial. Please don't do that. And I'm not saying that they're all, hoodwinking you. I'm not saying that. I don't know. All I know is I was raised with you don't get anything for free. And again, no one pays attention when they tell you eyeglasses, hearing aids, dentures, all that kind of stuff. From where? Make sure you know the product that you're getting. Remember what I told you guys? My patients wouldn't take generic. They would not take it. Part D came, That became the way you did it. If you did all generic, you didn't get the donut hole. So all my patients that never took generic, within a year of Part D, they learned you had to go generic or you'd run out of money in the donut hole. Similarly, from my end, I never thought Dr. Nicotero's patients would ever go anywhere but his office to get these services done that they were getting for 30 or 40 years. And I saw every single one of them. Not again, they didn't make the decision. The companies they work for made the decision, and now they travel everywhere to get testing done instead of at the PCP. I hope it was helpful, guys, and please make sure you understand that just because someone's telling it to you in such a way that sounds so believable, there's experts out there. And the money men and the attorneys know them. Like, these are groups, and I'll tell you how it works. A person that you might want to check with is, I forget the names. There's a term for the lawyer. If you lose a spouse or if a loved one doesn't have anybody, you go to see these people and they help you through the process of what to do with your dollars and cents. It's not a financial planner. It'll hit me the names of these guys. And I'm thinking of Chuck Parego. He's somebody I know from down in Bellevue. And that might be a name too. They're, like if you don't know an accountant well enough and you don't have a financial planner or a person, these people, it's terrible, I can't come up with the name right now of what their specialty is, but they're out there to guide you through these processes. And that's a name. Look Chuck up in the phone book or get him online or whatever his title is. Find somebody that knows somebody like that, because I forget, it's a planning type, but I forget what it's called. But these guys have the expertise because they do it every day. You don't want to go because of the commercial. You don't want to see somebody that doesn't have experience, and you want them to talk from their head. You don't want them, this isn't like you're going to pick out a carpet color or a paint color where someone throws a bunch of stuff in front of you. That's not the person you want. You want the person that can talk to you about all these programs out of their head because they've done it so many times. And like I told you, January of 20, they just changed the law. It used to go A to N, now F. You can't have G, H, I, J, K anymore. They got rid of those. Okay, those were high deductible ones. I guess Medicare didn't make money. Okay, guys, I hope I made it simple for you because that was the whole purpose. I hope I gave you a snapshot of what I witnessed going through the healthcare system and the changes. I started, there was only Plan A and Plan B, and what I saw were community hospitals shut down and changed the whole dynamic, and when the managed care hit, the next thing you know, all the hospitals I went to were shut down, and it wasn't controlled by doctors anymore. Now the good news is, I think the young ones are getting it. Like I said, I have 2 boys in medicine right now, and it seems like they're getting it. And that's my hope, that they find a way to gain more control and to say so of healthcare than it seems that we currently have right now.